Hello, my name is Lynn Keltika, and I'm employed by the CDC Division of Reproductive Health to work as a senior maternal and child epidemiologist in the state of Louisiana. This presentation shows the results of a hospital-based quality improvement initiative to reduce severe maternal morbidity among women with hemorrhage and separately selective hypertensive disorders of pregnancy, and to reduce racial disparities in the occurrence of SMM among these populations. The format of this presentation will be quite standard, presenting a background, methods, results, conclusions, and implications. The Louisiana Perinatal Quality Collaborative is a network of perinatal care providers, public health professionals, and advocates who work to improve perinatal outcomes in Louisiana. Louisiana PQC staff provide support to hospitals for targeted continuous quality improvement activities using improvement science methods. By design, each unique initiative lasts between 12 and 24 months. The first obstetric initiative of the Louisiana PQC was the Reducing Maternal Morbidity Initiative, or RMMI, launched in August 2018. Specific goals of the initiative were to reduce severe maternal morbidity, or SMM, by 20% among persons who experienced hemorrhage during their delivery hospitalization, or separately, to reduce SMM by 20% among persons who experienced selective hypertensive disorders of pregnancy, both by the end date of May 2020. As equity is a core focus of all Louisiana PQC activities, goals included decreasing the black-white disparity in SMM outcomes. Prior to the Louisiana PQC, the state engaged in quality improvement work through several mechanisms. Planning for quality improvement work on obstetric hemorrhage began in 2015 in collaboration with the Alliance for Innovation in Maternal Health, or AIM. The actual work began in 2016 in collaboration with the Louisiana Hospital Association Hospital Engagement Network. Louisiana continues to report outcome data on several severe maternal morbidity measures to AIM, including information disaggregated by race. Louisiana PQC began producing reports of low-risk first birth C-sections in 2020 in anticipation of the Louisiana Safe Births Initiative, which has now begun. In 2016, the Louisiana Hospital Association spearheaded a CMS initiative on obstetric hemorrhage that included over 30 Louisiana birthing hospitals. In addition to obstetric hemorrhage, hospitals continued to work on elimination of non-medically indicated or elective deliveries prior to 39 weeks gestation, work that had begun in 2014 within the Louisiana Department of Health. Some hospitals also participated in improvement work on obstetric trauma, and a few began work on severe hypertension and preeclampsia, predominantly through improvement to timely identification and treatment. This presentation reports data from the Louisiana Perinatal Quality Collaborative Reducing Maternal Morbidity Initiative, or RMMI, by addressing the following questions. First, from quarter 1 of 2016 to quarter 2 of 2020, what change was observed in SMM, excluding transfusion, among obstetric hemorrhage cases? Subpart, what, if any, change was observed in the black-white disparity in this measure? Second, from quarter 1 of 2016 to quarter 2 of 2020, what change was observed in SMM excluding transfusion among selected hypertensive disorders of pregnancy cases? Subquestion, what, if any, change was observed in the black-white disparity in this measure? Severe maternal morbidity, or SMM, was defined using the collection of ICD-10 codes identified through the CDC, which also corresponds to the definition used by AIM. For this initiative, the team was interested in quantifying the occurrence of SMM among two specific populations: those with an indication of obstetric hemorrhage, and separately, those with the diagnosis of selected hypertensive disorders of pregnancy. The corresponding ICD-10 codes used to identify these two populations of interest is available through the AIM website. Because dedicated quality improvement work began on obstetric hemorrhage and hypertension in 2016, Quarter 1 of 2016 was identified as the baseline. The official end of the Reducing Maternal Morbidity Initiative, or RMMI, was Mother's Day 2020. Therefore, Quarter 2 of 2020 was selected as the endpoint. Louisiana hospital inpatient discharge data, an administrative billing dataset available to the state, was used for identification of delivery hospitalizations, including those with diagnosis codes for obstetric hemorrhage and/or selective hypertensive disorders of pregnancy, as well as each of the severe maternal morbidities. Analyses were limited to the hospitals that participated in RMMI. Counts and rates were obtained through SAS-EG, and join point regression was used to identify trends by testing for changes in direction and/or intensity of patterns over time using alpha equals 0.05. We covered the basics of how the measures were identified using ICD-10 codes through administrative hospital inpatient discharge data. In greater detail, the population with an indication of obstetric hemorrhage included previa, abruption, antepartum hemorrhage, postpartum hemorrhage, or a transfusion that was not associated with sickle cell. The number of these individuals who experienced any one or more of the SMM diagnoses or procedure codes, excluding those who only had a transfusion but no other qualifying condition, form the numerator for the measure. The rate indicates the number of individuals with one or more qualifying severe maternal morbidities per 10,000 delivery hospitalizations of individuals with an indication of obstetric hemorrhage. These rates were calculated for the total population of patients in participating RMMI hospitals, as well as disaggregated by non-Hispanic white and non-Hispanic black race and ethnicity. For severe maternal morbidity excluding transfusion among selected hypertensive disorders of pregnancy cases, the numerator consisted of the same criteria as for hemorrhage, but the denominator included individuals with a diagnosis of pre-existing hypertension with preeclampsia, severe preeclampsia, HELP syndrome, or eclampsia. As with the hemorrhage measure, rates indicate the number of individuals with one or more qualifying SMM per 10,000 delivery hospitalizations of individuals with a diagnosis of one or of the selective hypertensive disorders of pregnancy, and rates were calculated for the total population of patients in RMMI hospitals and by race and ethnicity. There are a couple of noteworthy limitations in these measures. These measures were calculated using hospital inpatient discharge data, collected in part for the purpose of identifying diagnosis and procedure codes that are reimbursable to hospitals. SMM includes codes for 21 specific conditions, diagnosis and procedure, including transfusion. Although the coding for transfusion was required in ICD-9, which was retired in September 2015, even then there was no mechanism by which to quantify the amount of blood or products transfused. One criticism of the measure is that transfusion in and of itself does not necessarily indicate a severe morbidity, as 1 or 2 units could simply be within the course of usual care without indicating a severe morbidity. With the required transition to ICD-10 in October 2015, coding for transfusion was still allowed but no longer required for reimbursement purposes. Therefore, some hospitals chose to continue coding for transfusions while others did not. Because not all hospitals report these codes currently, the SMM measure excluding transfusion was felt to be more comparable across hospitals and therefore selected as the outcome measure for this initiative. Separately, for severe maternal morbidity among hypertension cases, it's important to note that eclampsia is a qualifying condition for both the denominator that also represents an SMM in the numerator. This overlap could potentially bias results in the measure of SMM among selected hypertensive disorders of pregnancy. Despite these limitations, SMM remains a measure reported in the peer-reviewed literature in addition to its use for the Title V block grant reporting, AIM, and other initiatives such as this. The measure is readily available from existing data and can be a useful tool, especially when used in conjunction with other measures to monitor changes over time. Looking at results. For severe maternal morbidity, excluding transfusion among women with a diagnosis of hemorrhage, among individuals who experienced an obstetric hemorrhage, the SMM excluding transfusion rate went from 1,037 per 10,000 delivery hospitalizations in Q1 2016 to 676 per 10,000 in Q2 of 2020. The rate at the end of the initiative was 35% lower than at baseline. Further, the results of join point regression indicated a statistically significant linear decrease of 2.1% per quarter over the time period of the initiative. Note that the trend did not change in direction or intensity during this time period. Rates by race and ethnicity indicated that rates among non-Hispanic white individuals were lower than among non-Hispanic black at most time points. Among non-Hispanic black women, the rate went from 1,423 per 10,000 to 722 per 10,000, 49% lower at the endpoint compared to baseline. Among non-Hispanic white women, the rate went from 683 per 10,000 to 576 per 10,000, a 16% lower rate than at baseline. The disparity was 2.1 at the beginning of 2016 and was 1.3 at the end of the initiative, indicating a reduction in the racial disparity as measured by these two specific time points. Compared to the overall trend, where a linear decrease was noted with no change in direction or intensity, race-specific results were different for SMM excluding transfusion among hemorrhage cases. The light pink line shows join point regression results for non-Hispanic white women, indicating no significant trend over time. The darker line represents join point results for non-Hispanic black women. Here we see that the results identified three distinct trends that occurred over the time period from baseline to endpoint. The first two lines from Q1 of 2016 to Q3 of 2016, and then additionally to Q4 of 2017, were not statistically significant. The third segment from Q4 of 2017 to Q2 of 2020 indicated a 5.8% quarterly decrease that did achieve statistical significance. Looking at the rates over time in severe maternal morbidity excluding transfusion among women with a diagnosis of selected hypertensive disorders of pregnancy, we can see that the severe maternal morbidity excluding transfusion rate went from 823 per 10,000 delivery hospitalizations in Q1 of 2016 to 728 per 10,000 in Q2 of 2020, the endpoint rate being 12% lower than the baseline rate. Rates of severe maternal morbidity excluding transfusion among individuals with selected hypertensive disorders of pregnancy were similar or lower for non-Hispanic white individuals compared to non-Hispanic black individuals at most time points. Among non-Hispanic black women, the rate went from 734 per 10,000 to 794 per 10,000, 8% higher at endpoint. Among non-Hispanic white women, the rate went from 1,096 per 10,000 to 751 per 10,000, a 31% lower rate at endpoint. The disparity was 0.7 at the beginning of 2016, indicating that non-Hispanic white women had a higher rate than non-Hispanic black women. By the end of the initiative, the disparity was 1.1. Results of join point regression for the total initiative population indicated no significant change from 2016 to 2020. This information was not shown. Similarly, there was no significant trend for either non-Hispanic white or non-Hispanic black women. In conclusion, the severe maternal morbidity excluding transfusion rate among hemorrhage cases was 35% lower in quarter 2 of 2020 compared to quarter 1 of 2016, exceeding the RMMI goal of 20%. The racial disparity in SMM rates among hemorrhage cases was 1.3 in quarter 2 of 2020 compared to 2.1 at baseline, indicating more equitable race-specific rates. Structured quality improvement initiatives such as RMMI have been shown to potentially be effective strategies to reduce disparities by ensuring that all women receive the same quality care every time. The severe maternal morbidity excluding transfusion rate among hypertension cases was 12% lower in quarter 2 of 2020 compared to quarter 1 of 2016, failing to meet the RMMI goal of 20%. More work is needed to better understand the SMM rates among hypertension cases and the factors that may have contributed to the smaller change seen in this measure. Reduction of severe maternal morbidity is critical to improving short and long-term unexpected complications of delivery. It is equally important to include equity in the work towards achieving improved outcomes, as quality cannot be achieved without equity. The Reducing Maternal Morbidity Initiative structure was successful in achieving some of its goals by reducing SMM among hemorrhage and addressing racial disparities, and may provide a model for consideration in other states. Although the RMMI initiative officially ended in May 2020, the Louisiana Perinatal Quality Collaborative continues to provide quarterly SMM rates among hemorrhage and hypertension cases to both LAPQC participating hospitals and AIM to support ongoing monitoring of progress in these measures. Please reach out to me through the conference mechanisms or at the email shown here for questions or additional information. Thank you for watching.